So next question states that there is a 32-year-old female who fell from her apartment in an attempted suicide attempt. Upon presentation, the patient had obvious head as well as extremity injury. But the most important thing is that the primary survey revealed that the patient is totally apneic. Now, what is the question? What is the method that can be immediately used to maintain the definitive airway? Should it be orotracheal intubation, nasotracheal intubation, percutaneous cricothyroidotomy, intubation over a bronchoscope, or needle cricothyroidotomy? In this scenario, orotracheal intubation will be the definitive airway securing step. When a patient who is having significant injuries and simultaneously their airway has collapsed, then there is a potential chance that the cervical spine can also be involved. Then in those scenarios, orotracheal intubation is attempted, but in line with stabilization of the neck. In case if it fails, then it is followed by percutaneous cricothyroidotomy. That will be the next step. So you have to see that what is the actual diagnosis and what are they actually asking in that question. These two parts will help you to identify the right answer in an effective way. So in the next scenario, a 17-year-old girl presents to the emergency with a stab wound to the abdomen which resulted into a fall. Her blood pressure is 80/nil, her pulse is 120 and respiration is 28. So we know that by now that the patient is in class 4 shock. Her abdomen has a stab wound in the anterior axillary line at the right costal margin. IV lines, nasogastric tube and Foley were inserted, and the blood pressure rises to 85 after administration of 2 liters of ringer. So what is the appropriate management in this scenario? Could it be peritoneal lavage, ultrasound, laparoscopic assessment, exploratory laparotomy, or CT scan of the head? So we have to establish our diagnosis. There is a stab wound injury to the abdomen and the patient is hemodynamically unstable. So there is only one option, that is directly going for exploratory laparotomy. However, if in the same scenario, initially the patient is having a stable blood pressure, then different options can be considered. But in case of hemodynamic instability, laparotomy is the best management step. So a patient without other obvious source of bleeding, in the scenario of a stab wound and being in shock, laparotomy is the definitive answer. Hemorrhage control should take priority as a definitive management over a secondary head injury. The other test will only be the wastage of time. To the next scenario states that there is a 22-year-old woman who presented to the emergency with the complaint of left upper quadrant pain after being punched by her husband. Her blood pressure is 110/70, which states that she is hemodynamically stable with a pulse of 100 and respiratory rate of 24. Now, the question states that the best means to establish the diagnosis in this scenario is done by using the FAST scan, physical exam, CT abdomen, peritoneal lavage, or upper GI series. As this is the scenario of a blunt trauma to the abdomen and the patient is hemodynamically stable, so the best choice to establish the diagnosis is by means of a CT scan. CT scan will help us identify solid organ injury with the amount of blood and help us identify the grade of that organ. In the left upper quadrant, it is likely to be splenic injury. So next question states that a 60-year-old man is attacked with a baseball bat and sustained multiple blows to the abdomen. He presented to the emergency already being in the state of shock. He was brought to the operating room and where a laparotomy revealed a massive hemoperitoneum and a satellite fracture of the right and left lobes of the liver. So what is the question? Which of the following techniques should be immediately applied? Pringles maneuver, packing of the liver, suture ligation, ligation of the right hepatic artery, or ligation of the proper hepatic artery. So in this scenario, packing of the liver is going to be the very initial step. So the initial step in terms of a liver injury is to perform packing. This is followed by Pringles maneuver. In this maneuver, the proper hepatic artery is compressed between one finger inserted in the foramen of Winslow and another anterior to the free edge of the lesser omentum. However, there is an important point that the selective right hepatic artery ligation is contraindicated. So first of all, we have the packing of the liver. This is followed with Pringles maneuver. So the next statement is that there is a 23-year-old man who is shot with a handgun and it is found to have a through and through injury of the right transverse colon. There is little fecal contamination with no bowel devascularization. At operation, what should be done? Right hemicolectomy with iliotransverse colonus anastomosis, right hemi with ileostomy, debridement with closure of the wound with exteriorization of the colon, or debridement and closure of the wound, segmental resection with primary anastomosis. So the answer in this case will be debridement and closure of the wound. Most gunshot wounds to the right side of the colon should be closed primarily. Resection is only required when there is extensive devitalization of the tissue or injury to the mesocolon causing devascularization. So in this scenario, they have already established that there is no bowel devascularization. So our option will be to perform simple debridement and close the wound. So a 20-year-old female presents to the emergency after having a stab wound to the abdomen. There is minimal abdominal tenderness. Local wound exploration indicates that the knife penetrated the peritoneum. So what is the question? That what is the ideal use of antibiotic in this stab wound scenario? Should it be used preoperatively, intraoperatively, postoperatively if the fever happens, postoperatively based on the culture sensitivity, or intraoperatively if the hollow viscous injury is found? So in this scenario, preoperative antibiotic is going to play an important role. Antibiotics should be given to all preoperative patients with a wound which has penetrated through the peritoneal cavity. Intraoperative and postoperative antibiotics will fail to reduce the postoperative abscess and wound infection adequately. So the next question states that there is a 70-year-old woman who was hit by a car and has injured the middle of the abdomen. Now, what is the best way to rule out rupture of the second part of the duodenum? Repeated physical examination, ultrasound, amylase level, CT with the use of oral or intravenous contrast, or peritoneal lavage. Now, in order to identify the rupture of the duodenum, CT with oral and intravenous contrast is going to be our investigation of choice. CT with oral and intravenous contrast is very sensitive and specific study to identify retroperitoneal hematoma in the duodenum. Findings on physical exam and peritoneal lavage are generally negative because of the retroperitoneal location of the second portion of the duodenum. So the next question is that there is a 35-year-old woman who is punched in the right side of the abdomen and chest. There was some right upper abdominal tenderness, but with no guarding or rebound tenderness. Results of a gastrographin upper GI study showed a coiled spring, that is the stack of point appearance, in the second and third part of the duodenum. So what is the most likely diagnosis? Does this indicate rupture of the duodenum, contusion to the head of pancreas, or an intraluminal blood clot, retroperitoneal hematoma, or duodenal hematoma? Now, coil springed appearance or stack of point appearance on gastrographin upper GI studies are diagnostic for duodenal hematoma. So, what should be the appropriate management in the above patient? That is hematoma of the second or third part of the duodenum. So, what should be the management? Should it be followed with respiratory laparotomy and drainage, duodenal diverticalization, pyloric exclusion, repeat upper GI CDs after 5 to 7 days interval, or CT guided percutaneous drainage? So there is an important concept that in case of a duodenal hematoma, it should be managed conservatively, as I have explained this in question number 1 as well. So oral feed and fluids are withheld. However, upper GI studies are repeated at a 5 to 7 day interval, and surgery can be avoided, and it is only used if there is permanent obstruction because of an extensive injury. So 15-year-old girl had an injury to the right peritoneum with duodenal contusion. What is the test required to exclude the rupture of the duodenum? Serum amylase, Hydascan, gastrographin study, upper GI studies with use of barium or ERCP. In this scenario, to establish the rupture of duodenum, our best option will be gastrographin study. So the rupture of any coloviscus, not only the duodenum, can be used with the help of a gastrographin study, because extravasation of the component used in this study will help us identify not only the location but also the degree of perforation. So contusion of the head of pancreas might show a widening of the duodenal pseudo. If barium enters the peritoneal cavity, it can cause severe pancreatitis. So that is why gastrographin study is used, because it is water soluble and it is less irritating.